Hey there, I'm Ben.
I'm Janelle,
I'm Ryan.
and we're here to talk to you about our case study today. It's updating clinical guidelines for pain management in an oncology unit. In an oncology unit of a busy hospital, nursing leadership faces a scenario that necessitates a change in clinical guidelines for pain management. The unit primarily cares for cancer patients undergoing various treatments, and pain management is a critical aspect of their care. However, concerns have arisen regarding the adequacy of the current guidelines. So first is opioid stewardship. The opioid crisis has prompted increased scrutiny on opioid use in healthcare. The current guidelines may not reflect the latest evidence-based practice for opioid stewardship, including strategies to minimize the risk of addiction and overdose. The second is patient-centered care. There's a growing recognition of the importance of patient-centered care, including individualized pain management plans tailored to each patient's unique needs, preferences, and cultural factors. So I'm going to briefly explain Lewin's change theory. First is unfreeze. This is to identify resistance and build driving forces. The second is movement, which is continuous feedback, refined as needed, and encouraging positivity. And then last is refreeze. This would be to evaluate, analyze, look at results, and collaborate the successes.
Okay, so next up, we need to, in order to better look at this problem, we need to identify potential areas for improvement. So below are some areas where improvement may be warranted. First up, we've got opioid stewardship practices. So within this area, potential over-reliance on opioids without comprehensive monitoring or alternative pain management strategies maybe exists. In an article regarding opioid stewardship in perioperative setting, it is understood that the lowest dosage, shortest acting opioids are important to use while maintaining effective pain control and patient satisfaction. Next, we've got education and training. Possible gaps in nursing and clinical staff knowledge regarding non-opioid alternatives, multimodal pain management, and safe opioid prescribing may exist. Next up, we've got documentation and communication. Inefficient communication of pain management goals and plans across interdisciplinary teams might exist as an issue. There also may be a lack of standardized pain assessment tools that are used consistently within staff members. Finally, cultural competence regarding pain management. Inadequate consideration of patients' cultural beliefs, values, and expressions of pain, which may lead to under-treatment or misinterpretation of these symptoms. So after identifying all of those, we're going to identify actual areas of improvement. So based on our scenario, the actual areas of improvement include outdated pain management guidelines being first. Current clinical guidelines do not reflect best practices for opioid stewardship, and there is a need for a global adoption of universal optimal pain management and opioid stewardship protocols. Second on the list, there's a lack of individualized pain plans. So guidelines here fail to support truly patient-centered care models. There could be missing individual needs, there could be pain thresholds that differ, there could be a difference in past pain experiences, and there might be cultural considerations that are lacked in these pain plans. Next up, there's limited use of multimodal approaches. Within this, heavy reliance on pharmacological, especially opioid-based, interventions with minimal integration of non-pharmacological therapies such as acupuncture, acupressure, or aromatherapy, just for example. According to a systematic review and meta-analysis by Yan et al. In 2025, non-pharmacological methods can increase quality of life and improve the efficacy of pain management in tumor patients. Next on the list here of actual areas of improvement is inefficient monitoring for opioid use disorder, or OUD. There may not have a formal screening or follow-up process for identifying patients at risk for or currently experiencing opioid use disorder. According to Prude et al. In 2022, in an article addressing opioid use disorder prevalence, about 8% of patients that have cancer have opioid use disorder, making this a large issue. Next, there are communication barriers and cultural issues affecting care. And moving on, we have preconceived notions of pain management regarding both the nurse and the patient. Patients may expect to have absolutely no pain at all, whether this is realistic or not. And nurses may treat all pain the same, regardless of that patient's background, or of that patient's pain goals, or of that patient's current level of pain. And moving on, there's education on opioid stewardship. So within this, as medical professionals, we need to educate our patients. There may be an area of improvement for the current opioid crisis that has happened before, is happening currently, and may happen in the future. Another area for improvement may be storing of medications, and this could hopefully reduce theft. Another area that we're looking into is not being able to share those medications with others, and when to take these medications. Another area of improvement is tolerance of to these medications, their addiction potential, and the use of naloxone or Narcan. And finally, another actual area for improvement could be use of alternative methods such as non-pharmacological pain relief. Okay, moving on, we need to be able to determine who may be needed to assist with these changes. To implement sustainable and effective improvements, collaboration across disciplines is critical. A couple of key stakeholders include the nursing leadership and staff. Frontline staff is responsible for pain assessments, their intervention, and patient education. There's also a palliative care team. These experts are proficient in managing complex pain and symptom control in our oncology patients. Next are the physicians, so oncologists, pain specialists, for medical oversight, prescription of medications, and revised pain management protocols. These physicians and experts can look into all of these. There are pharmacy services, so pharmacy to provide opioid medications timely when needed and ensure that medications are appropriately prescribed. We also have patient sitters. These individuals provide emotional support, remind patients to utilize the non-pharmacological methods taught by the nursing staff as well. And there are also bilingual staff or communication platforms. So this aspect assists with language barriers via HIPAA-compliant telehealth communication assistance platforms, or the use of bilingual staff to help overcome potential cultural barriers.
So with all that being said, we have a bit of an action plan to address this issue. And we're going to use Lewin's model to address this issue. The first step in that plan is to unfreeze. So in this step, we need to identify the need and prepare for change. So in this step, we ask, what do we need? So we need to create awareness and readiness among staff to update pain management protocols and tactics. We need to prepare for the change that is being made. So the way that we are going to prepare for the change is to gather information. And we're going to do that by collecting data via patient surveys, research, company history of opioid-related adverse effects. We're going to review charts for inconsistent pain assessments. So if, let's say, we assessed pain and their pain goal was a 5, and their pain was a 5, and in an hour it was still a 5, and we didn't give another pain medication, we would ask why. We would gather staff input on the situation, and so that's step 1 of the unfreeze as part of Lewin's model. Step 2. So we're going to initiate the change. We're going to put that plan into action. So we're going to put that plan into action by moving from creating awareness about the situation and gathering information to launching these new processes. So we initiate the clinical pain management protocols, and we're going to do that. We're going to make sure that our staff know how to do that, how this new process is going to work, how we're going to standardize our pain assessments, and really tighten up the ship. And we're going to do that by training staff via online modules. We're going to hold paid in-person trainings that will be required and mandatory to attend. And we're also going to hold simulation-based learning situations, just to kind of reiterate everything that's learned in the online modules and in the in-person trainings. So once we implement the change, we're going to collect the feedback from the staff and also from the patients. So we're really going to be analyzing, is this working? Is this effective? Is it doing what it's intended to do? And step 3, so we're going to refreeze, in Lewin's model, refreezing. As part of this scenario, we're going to focus on the maintenance of the protocols. We're going to make sure that these protocols are long-lasting, that they're not fleeting changes, that we're not just reverting back to the way that things were before, because that does often happen. We're going to revise policies and procedures. So once again, analyze if this is working. And we are going to continue to monitor patient scores and adverse opioid-related incidences. So we'll expect to see that these incidences are going down. We're going to reinforce morale by posting these in company emails, these results, in company emails or staff bulletin boards. And we are going to require annual education for all staff that is responsible for administering these pain medications regarding pain management and opioid stewardship. So in conclusion, making updates to the current clinical pain management guidelines for an oncology unit is an important step that can improve patient care, ensure opioid stewardship, and support tailored individualized treatment plans. By applying Lewin's change theory, we can make sure that a smooth transition happens using evidence-based practices that can address opioid use issues. The collaboration of multidisciplinary teams such as nurses, physicians, pharmacies, palliative care, and utilizing various communication platforms can lead to successful changes in the oncology unit. Continuous education, constructive feedback, and effective reinforcement can make sure that these improvements are sustainable and lead to better outcomes for the unit's cancer patients. And these are our sources.
Thank you.
Thank you.